Hello, everyone. My name is Charon Gwynn. I'm the Deputy Commissioner for the Division of Epidemiology at the Department of Health and Mental Hygiene. I'm super excited to be here today to talk to you about using data better. This is the Using Data Better panel, for those of you who aren't aware, or sorry, Use Data Better panel. It's been a great morning, so hopefully you guys are invigorated for the rest of the day. It's really been inspirational to hear about the different programs and interventions from across all the cities that are present here today. Mental health is clearly a cross-cutting issue, but I think learning about the programs that are happening across the country in the different cities is really again, it's very inspirational and gives you a sense that there's action that can be taken to move the needle. So I have the wrong handout, so just give me a second. So we're going to be talking today about ways that we can identify and help spread innovative mental health interventions, especially with a focus on more nimbly gathering and using data. The panelists here are going to talk about their approaches to use data better, but also to enable community partners and to use data better and also to implement best practices. My division in the Department of Health here in New York City is really focused on population surveillance through data collection, through surveys, and using data from administrative records like death records and hospitalization records to help inform public health programming in the agency. We also work to develop and implement to conduct research and innovative research and evaluation. So that is why this panel is especially important to me, because it's exciting to learn about the interventions that are happening and how folks are using data to inform those interventions and also assess the effectiveness of those interventions. We also, at the Health Department in New York City, have a focus on health equity. So we like to apply a health equity focus on much of the work that we do, and so that we can be very intentional in serving the communities that we work with, using evidence-informed and data-driven approaches. Today, we're going to hear from 5 jurisdictions, including New York City, about work that they are doing to improve mental health using data through both through coordinating care, through using data, improving data sharing, standardizing quality improvement across mental health agencies, and providing data using data to target the populations of greatest need. I'm going to quickly introduce each of the panelists, and then we'll allow each of the panelists to give their presentations, and then we'll come back and have a larger discussion. So starting at my left, we have Andrea Ault-Brutis, who is the Senior Director of the Mental Health Innovation Lab in New York City. Next, we have Kalene Gilbert, who is a Mental Health Clinical Program Manager in LA County Department of Mental Health. We have Maria X. Martinez, the Chief Integrity Officer at the San Francisco Department of Health. Marna Miller, who is a Senior Research Associate with Washington State Institute for Public Policy in Olympia, Washington. And then we have 2 representatives from Tennessee. We have Scott Ridgway, the Executive Director of the Tennessee Suicide Prevention Network, and Misty Leitsch, who is the Zero Suicide Coordinator in Tennessee. So in just a moment, each of the panelists will share an overview of their work. They're going to focus on how their work advances and informs this key principle, which is use data better. And then we'll lead to a discussion about the question, can cities drive and spread new ways of gathering and using data and build capacity for community actors to test and innovate as well? So with that, let's start with Andrea Ault-Brutis, who is here in New York, the Director of the Mental Health Innovation Lab.
Hi. Thank you.
Okay.
Good afternoon, everyone. Great. So the lab itself is a bit of a, we're the newbies, I think, at the table. The lab, Mental Health Innovation Lab, has been around for a year as an idea, and we really started to build up the lab in terms of staffing in May of this year. And I came on as the senior director for the lab in August. So we pretty much hit the ground running with the type of work that we're doing. So just to give you an overview of the functions of the lab. So we have two main areas for the lab. One is focusing on new ways of collecting data and helping our stakeholders put that data to use. And another main function of the lab is to help drive the use of evidence-based practices throughout New York City by piloting and disseminating best practices and providing implementation and quality improvement support to our stakeholders. So I'm just going to go into a little bit more details about these functions. So in terms of best practice dissemination, we convene meetings, synthesize evidence, and disseminate briefings on emerging and innovative strategies, interventions, and population-based approaches in mental health. In terms of providing QI implementation support, we work with our stakeholders, whether it's other bureaus within Department of Health and Mental Hygiene, healthcare organizations throughout New York City, community-based organizations, faith-based organizations, giving them, helping them understand the importance of quality improvement and how implementation science could support the initiatives that they're doing, helping them understand the value of a CQI, a continuous quality improvement culture, and training them and supporting them in those types of endeavors. In terms of data innovation, we look for new ways of collecting data, whether it be using smartphones, using sensors, apps to help with collecting data in real time. We're not doing that right now, but we're hoping to move towards that. And also providing research and evaluation support. We provide technical assistance to evaluations that are going on with the Thrive NYC initiatives. We're also helping to understand Thrive as a whole, how it may be impacting population level data metrics within New York City. So we're helping City Hall with identifying those type of macro metrics to see how things are changing across the board in New York City as a result of implementing the 54 initiatives for Thrive NYC. So overall, we're hoping to create what I like to call what's been defined as a learning behavioral health organization, and helping to develop a culture of using data to drive that. I'm just going to go a little bit more into some of the programs that we're doing. So earlier this year, the Department of Health and Mental Hygiene met with leaders from faith-based organizations and community-based organizations, mostly immigrant groups. And they did a focus group with them, and the members who attended that focus group said that they wanted education and skill-building materials they could use to help to provide mental health care to their members. And so with that information from the community, we decided as a department to launch what we're calling a virtual learning center, where we'll be providing training on different modules, training modules, for example, problem-solving therapy, self-care, motivational interviewing. These are types of interventions we feel that can be typically are done by mental health providers, but could be task shifted to members of the community so that they could be the ones to give frontline behavioral health support to their members. So we're launching that in December, and we're going to be starting with training on self-care and then launching problem-solving therapy after that. But we're hoping that this enables community members to be those frontline people, because oftentimes, as many of you know, members from these types of groups, whether it be racial ethnic minorities or immigrant groups, they tend not to seek behavioral health care in a behavioral health setting. And so therefore, we're trying to bring that type of services straight to them as opposed to having to force them. Sometimes they don't really want to go into a behavioral health setting to get that kind of care. So we're hoping this type of task shifting would be beneficial to the community, and we'll evaluate it also to make sure this is of value to the community. In regards to quality improvement, we have collaborated with 50 community-based organizations in the South Bronx and Brownsville, New York, and helping them to learn about QI. We're partnered with the Institute for Healthcare Improvement, IHI, out of Cambridge, Massachusetts, and they're partnering with us to teach these CBOs about how to use QI methods. And the goal of that program is to help them with early childhood development, looking at healthy pregnancy, school readiness, and secure parent-child attachments. So we're working with these 50 CBOs to help them develop these quality improvement programs to achieve those outcomes. Going forward, we're hoping to do some more work with in mobile health. We want to identify apps that could be used with our community members in terms of collecting data in more real time, engaging people with mental health disorders in telepsychiatry types of interventions, and helping to encourage networking, peer networking between those who are suffering from mental illnesses to hopefully stimulate engagement and improve retention and care. So those are some of the types of programs that we currently have going on. Again, we're relatively new to doing this, so I'm looking forward to hearing about the exciting work that my colleagues are doing, and I'll end it there. Thank you.
Hi, everyone. My name is Martinez, and I'm with the Department of Public Health in San Francisco. And thank you so much for the invitation and for an opportunity to talk about a project we've been working on in San Francisco since 2003. So, and I 7 minutes in 13 years. So I'm going to try to do this really fast. I'm going to try to talk about how we started, and then where we've ended today, and a little bit where we're going. And I'm going to try to get in between all of the challenges that it took us to get to where we are today. I have a handout. I didn't have enough to put on every chair, so if you don't have it, I'm happy to send it to you. So the Coordinated Care Management System was born in 2003 when I was assigned to work in the health department to work with the fire department where the ambulance services came out of. Totally different agency, never talked to each other, never worked together before. I got about 2 years worth of ambulance data, and I analyzed, I'm an analyst, so I took all the data and I identified the top 10 users of EMS, ambulance use, and brought together people in the health department with the fire department because there was a sense that emergency rooms were being clogged up with certain types of people. But nobody really had any information. So I got this data from the fire department, ranked the top 10, pulled people together in the health department and said, do you know these people? And nobody knew them. So I said, okay, well, let me go to our 3 main databases. We have 75 databases in the Department of Public Health that do not talk to each other, that has protected health information in them, 75 of them. Let me go to the top 3. I will pull the health data from those 3, pull it together, come back, and we'll meet and talk about these folks. It took me 6 months to get health histories on 10 people. And I swore I would never do that again. So I did do it, and it was very informative in terms of the amount of behavioral health services that these individuals had gotten, because I went to the medical system, the mental health system, and the substance abuse system and pulled it in their data. While I was doing that, to try to begin to work with the fire department in a new way, we also, under then Mayor Gavin Newsom, started the San Francisco Homeless Outreach Team. We implemented a sobering center and a medical respite. And all of these programs didn't fit into any one of those 76 systems. They weren't purely medical, they weren't purely psych, they were population focused. And so I had to go to our IT and say, can you help me create a system where we can track who's coming in, how they're going out, are we effective? As a performance analyst, I wanted to know these things. And so we created something in an Oracle database. So it was the 77th system. And so we started pulling this together, and I was also implementing the Homeless Outreach Team and doing the high EMS user collaboration with the fire department. And as I was listening to them talk, and we were creating this Oracle database that had little applications, and I was collecting this information, and I said, well, let's just use the same people in the middle. And so if you create a new record and it says, we'll just use the same people here. I know all you IT people, I'm not a techie, but so the sense was that there was this repository of names, and they would come in, open the door, and create a record in these things. And so as I was working with the Homeless Outreach Team, they were saying, you know, these people are really, really sick. We're out there in the streets, under the freeways, they are physically really, really sick. And I said, well, maybe we should look at their medical histories. San Francisco has 4 agencies. We have the health department, we have the human services, we have a new homeless department, and we have EMS. They don't ever talk to each other. And then, as I said, we have all these systems inside each one of those that don't talk with each other. And so we said, well, maybe if we took this repository and at midnight, went over to the medical system and said, could you please give us their medical history, not everything, but some of it. And then anybody we don't know, we identified this was just going to be a vulnerable database. We were going to figure out who was vulnerable. Anybody who's ever known to be homeless, anyone who's ever used an urgent emergent service in any one of those systems, anyone who's over the age 60. We've since added anyone who's African American as being a high-risk group. So what are the high-risk factors that we want to track? And so we started that in like 2003, and around 2006, Atul Gawande came out with the hotspotters. Maybe you heard about it. A revolutionary kind of idea that people come together, packages full of problems. And that time I thought, well, the homeless outreach team says that they're really having a lot of problems with these folks on the street. How can I begin to capture this information? So we systematically went to these big databases and said, can we borrow your data? You don't have to do anything different. Just at night, we're going to come in, we're going to pull in key pieces of medical. We're going to come in and pull in key pieces of their psych history in a different system. So we eventually hit 14 different systems that were in these 4 different agencies. And these were vulnerable folks, and so if any one of those systems ever, in any of their history of data, ever said they were homeless, I was going to pull them in. So if they hit one of those indicators, I'm going to pull them in. So now we have 450,000 unique people who have over 20 years of health and social histories known about them. And so that is a lot of information. And the challenge has been trying to understand the high-risk population within those 450,000 people. We are able to say what our unique number of homeless people are in San Francisco, not because of one night going out and counting, but because we have this longitudinal information of when somebody was homeless the first time in 1982, and they're still homeless because we're getting shelter data. We're getting housing data. We're getting jail data. We're getting death registry data. We're getting all the medical, all the psych, all the substance use. And for the 42 CFR Part 2, we hadn't touched any of that information today, but that's probably one of the most dangerous privacy laws there, because I can pull in the information, but I can't give it back out. Let's see, we have county assistants. We have all of their services of when they're going outside of our system. So through the health plan, we have, through ACA changed a lot. For the health plan, we know when our members are going over to other hospitals, so we're pulling in that information. So we have a tremendous amount of information about our vulnerable population in San Francisco. And so what the hell do you do with all that information? It is so much, so overwhelming. So we took the idea of the hotspotters and we looked at what we now call HUMs, high users of multiple systems. And so high users of multiple systems are people who go through these systems like this. They're high users over here and kind of over here. And so we count the services of use of urgent emergent care. And we do it in the medical is the typical ED, inpatient. We have a medical respite, ambulance. But we also look at the mental health system. So we look at crisis, mobile crisis. We look at psych emergency. We look at psych inpatient. We look at some other things in psych. And we also look at the substance abuse treatment system. And the 3 urgent emergent services we look at are detox, medical detox, social detox, and the sobering center. So we collect that activity, and then we take the top 1%, top 5%, above 50%, and then below 50%, and stratify them based upon their use of urgent emergent services. The top 5% users of urgent emergent services constitute over 50% of the costs. So we, again, start looking at who are the highest, most vulnerable population. These are all adults for right now. Children and families have a whole different architecture, but so we're focusing on adults, and we're able to create information about our homeless population. And how much time? I could talk all day on this stuff. So how do we get from here to here with all this information? It took, I would say there are 4 things that you have to deal with. How many people here have IT underneath them? Okay, so that to me, I'm the privacy officer, that was really helpful. Because I can say, yes, you can, yes, you may, yes, you will share this information. It's a little bit harder when you have privacy and law thinking about things differently. San Francisco has all the health services, especially for vulnerable populations, underneath its, what do you call it? I was a privacy officer, so I could say, yes, you can. If it was a whole different agency or a whole different company, I probably couldn't enforce that. So we had, even though it's tough, it's a cultural thing. Sharing information across systems takes a lot of trust, takes a lot of, you have to earn it. But to me, that was not the biggest hurdle. It may be, and I've heard it in other counties where it is a hurdle. For us, it was a process, it wasn't a dead end. The second thing is leadership. Leadership because every one of our, implementing an EHR is a full-time job. The thought of doing something in addition to that just puts all these healthcare systems on tilt because they can barely keep their lights on. And it doesn't really matter where you go. IT, there's never enough people, there's always more demand. And so for me, IT was the largest challenge. And leadership is really key because you're going to have to take the long view on this. This is a process. You're going to start trying to align bureaucracies. And so that leadership is key. If it hadn't been for Barbara Garcia, who's the director of health, over the past 13 years, this would not have happened because the priorities are we're on fire to try to get a new EHR in. We are on fire to try to keep the lights on. So leadership is really important. In terms of where we are now, with the work that we've done in San Francisco has led the Medi-Cal waiver in California for what's called whole person care. And, excuse me. That is a waiver that over the next 5 years, counties are applying millions of dollars to try to redesign how they are delivering care, to not only look at the medical and the psych, which, behavioral health, substance abuse falls in between one of those two, but it's harder because of the privacy laws, but also looking at the social services. So housing is key. Looking at their entitlements. So whole person care, millions, like $900 million or something like that in California is going toward counties to help them over the next 5 years figure out how to implement whole person care. In addition to that, and hopefully with that, the biggest challenge that I think we are now is that data doesn't change anything. Data helps make change happen because it can convince people that, yes, we do have an overlap, or yes, we can see change. For example, I did an overlap analysis with the Department of Aging and Adult Services and was able to say to them, it's important that we begin to share information because we're sharing clients. And when we did an overlap analysis, it was a one-time thing, we had hardly any overlap. And that's a problem, that our patients are not getting to each other. So data is really important for affecting the motivation for change. But with it alone does not change the way we practice. And if there's anything I've looked at, comparing the high medical users to the HUMS users that we look at these things, we can see that the trimorbidity in the high users or in our HUMS is significantly higher than if you're just to look at the medical high users. And so this kind of information is really important in making change happen, but it doesn't change the way we practice medicine. It doesn't change the way that we ask poor people to go to yet one more place. It doesn't change anything unless there is a really, really strong commitment to transform our systems. And that's probably the one thing that I've learned the most, is that for us to really make a difference in the lives of the people that we're serving, we have to have a revolution about the way we package how we make poor people walk into their health. It is incredible. I mean, dozens of places that we ask them to go to, dozens of psychiatrists who don't know each other, prescribing yet again something and yet again in an urgent area. So that's kind of where San Francisco is right now, is that it's incredibly powerful, it takes a lot of work, and it is just the start.
So, good afternoon. I'm Kalene Gilbert. I'm the district chief for the Los Angeles County Department of Mental Health Children's Systems of Care. And first, I am also honored to be here. This has been really an exciting time, just listening to the panel this morning and last night. My wheels are definitely turning. I'm looking forward to sharing some of this when I get home. So, first, just for some context, as I talk about data and use of data in LA County DMH, and in case folks don't know, LA is big. It's really big. We're about 4,700 square miles, and we have an approximate population of about 10 million. And we utilize, well, actually, we have about 12 threshold languages, and so we're incredibly diverse. And all of those things impact how we think about creating, delivering, implementing, and monitoring our services. So we use data, broadly speaking, at every step in the process. We use demographics data. We work with our partners and look at their tracking data to help us identify need and look for service gaps. We use utilization data, help us flag issues that might be coming up around service utilization. It helps us maybe flag issues and brings us to the table, maybe facilitate the problem-solving process. We also use outcomes data to help ensure effectiveness and accountability. So for this piece, for my piece, I'm going to go really deep into the weeds, though, and talk about this process just through one of our programs, and that's the parent-child interaction therapy. So I'm going to get super into the weeds here for a second. I'll try to keep this brief. So the problem started when we looked at data shared with our Department of Children and Family Services. We have about 20,000 per year, about 20,000 shared open cases with Department of Children and Family Services, a third of which are ages 0 to 5. When you look at DCFS data in general, home removals, a third of them are about 0 to 5. And we don't have a whole lot of programs in place right now to serve that population. And we know now that trauma and the impact of trauma can stay with the child and the family throughout their lifetime, can affect their health, can affect their mental health. So we thought it was important to start to look at preventative and early intervention strategies. LA County, or actually the state of California, has prevention and early intervention funds that started about with our Mental Health Services Act. That was about in 2004. So we had funding identified to help us with prevention, early intervention efforts. So we looked for intervention strategies, multiple strategies, but one that we landed on was PCIT, parent-child interaction therapy. And if you've not heard of it before, it is it's an interesting strategy. It's one in which the clinician will coach the parent who's working with their child on the other side of a one-way mirror. The parent's got a little bug in their ear, and the clinician is watching and is able to help the parent through certain kinds of interactions with their child. It's meant to reduce aggressive and negative behaviors. It's meant to reduce parent stress. It's meant to increase parent effectiveness. And overall, we want to improve that relationship between the parent and the child. And hopefully, we're looking for ways then to start to intervene and keep families out of the child welfare system and keep families together and help them thrive. So as we began implementing this practice, we found in one of our local partners, First 5 Los Angeles, also had an interest. That's their mission, is to address the 0 to 5 community. They're also looking at lots of data. They fund something called the Child Data Network in California, which is a partnership between USC, First 5 LA funded, and a couple of other agencies. And what that group does is they pull data from all sorts of different agencies and government entities, and they try to tell a more comprehensive story of pulling the pieces together or connecting the dots, so to speak. So they too were looking for some intervention strategies, felt PCIT was something worth investing in, and we partnered together to do a huge expansion of PCIT across LA. So then we needed, from there, we worked together to look at, well, we had to figure out how much, we had to figure out where would we do these, where would we implement, where would we expand these services, and we also had to think about cultural competency. What were some of the language and cultural needs if we wanted to implement this more broadly? And so working together through their data systems, working with Department of Children and Family Services and their data, we were able to identify concentrations where there were the most removals. And while we know the reasons for that are systemic, this is where we wanted to target this particular intervention. And we were able to map that with our provider network so we could target particular providers to participate in the trainings. So First 5 LA funded us with a huge grant to expand training. They paid stipends for practitioners. They helped to build out all of the rooms. There's a lot of facilities. You got a two-way rear. You got to build all of that out. And so we were able to implement that much more broadly. We're about 3 years into this implementation. We've got another 2 to go, and so far it's been pretty successful. So I also want to comment on how we utilize data along the way. I mentioned during implementation phases, it's been really key to us where we start to look at, we want to make sure, first of all, that it's being utilized, right? We're training folks, we want to make sure this is a practice that's getting used. So we look at key indicators. And in some places, we started to note some drop-offs. And when we were able to look at outcomes, we started to see that there were families that were dropping out early. And in talking with the team, we found out, and talking with the providers, we learned that there was childcare issues. So from that, the data red flag, we were able to then investigate, work with providers, and then work with our partners with First 5 LA to use grant funding to be able to address childcare needs and transportation needs, which very quickly changed the picture, and we saw participation go up pretty quickly. So we're able to now monitor that and hopefully use that to make some arguments for some of our other funding sources, seeing that this is a pretty critical piece of what we do. So, and then of course outcomes. We do individual-based outcomes, and those are absolutely critical. And the bigger challenge for us around outcomes is just the size of our network. And so I know we're going to get around to challenges in just a little bit, but those are really key, both for accountability, and of course we want to make sure these services are effective. So that's my time.
Hi, I'm Misty Leitsch. I'm the Zero Suicide Coordinator for the Tennessee Suicide Prevention Network, and I'm going to ask that my boss, Scott Ridgway, kind of give an introduction of who TSPN is, and then I'll follow up more about the Zero Suicide Initiative.
Well, first of all, we appreciate the mayor's office for hosting this event. Anytime there's an opportunity for us to talk about suicide prevention, it's so important, because I know some of you all in this room have lost a loved one to suicide. And the first thing that I want to say to you all is I'm very sorry for your loss. Where we lose someone to a car accident or someone that dies by a heart attack, that's a loss. But for those people that have lost a loved one to suicide, it's very traumatic, because we ask those questions of what we could have done, what we should have done, were there warning signs, and so forth. Tennessee happens to be a national model as it relates to suicide. Back when Dr. Satcher, when he was the Surgeon General during Clinton's administration, released the national strategies for suicide prevention and the call to action, and asked states across this country to address suicide prevention. As we lose close to 41,000 Americans on an annual basis, and that number continues to rise, which really tells us that over 108 individuals die by suicide on a daily basis just in the U.S. Data is very important. Tennessee answered that call many years ago. I've been serving the executive director for the last 15 years and have had the privilege of working with so many folks with this cause. We're a statewide network. We have over 20,000 folks that are involved in our network and on our distribution list. We've updated our strategies, and we even have an evaluation process. Outcomes are so important with what we do, and we depend a lot on our advisory council that's appointed by the governor. It is a nonpartisan issue. We've gone through 3 different administrations where we really believe that suicide is very important, and one suicide is one suicide too many. Data is so important. I remember my first time going to Washington to visit our congressional staff. We have 11 congressmen from our state in Tennessee, and I'm always really fast to make sure that we're going to try to do the best we can. And I can remember one day that we called to speak to one of the congressmen to set up an appointment in Washington, and basically the congressman said that he did not have the time. That he had a really busy schedule, and out of our other 10, we were set those appointments. And we took the numbers of suicide in his congressional district for 5 years, and were able to send an email and send it to him and say that during the last 5 years, you've lost X amount of folks in your congressional district, and within 10 minutes, we received an email. Data is so important that he would see us. The governor not only appoints the advisory council, but in our state, all of our commissioners from our major departments designate a person where we have a interstate departmental group where we meet on a quarterly basis, where we're always working to look at how we can come together and look at those issues, whether it's data, whether it's outcomes, whether it's memorandums of understanding. We happen to have the privilege of receiving funding. We are not a nonprofit, and we're not a state agency. We're a public-private network where we want everyone involved, and we think suicide is everyone's business. We have received federal funding from SAMHSA, and Misty will a little bit talk about our Zero Suicide Initiative, and we really believe that data is so important, where we chose and had selected Zero Suicide as being one of our initiatives.
Thank you. So in Tennessee, we have 23 different agencies participating in the Zero Suicide Initiative. Excuse me. Anyone in here familiar with the initiative? Okay, so a couple. So for the rest of you guys, there's 7 dimensions to this particular initiative, and one of the dimensions is data, and I'll talk about that in just a second. The first dimension is about leadership and really changing the culture, which is a very common theme that you've heard all morning and this afternoon. Getting leadership buy-in, changing the culture so that it trickles down from the top to bottom. The second dimension is about training the workforce, developing a competent, a caring and workforce so that as the community sends friends, family members for treatment, we know they're receiving effective care. It's critical. You can build infrastructure, you can make referrals, but if you don't have a workforce that is ready and capable of handling and working with and treating this population, then we're doing a disservice, okay? The next dimension is identify, and that's really about using best practice screening tools to identify those individuals who are at risk or suffering from a mental health issue. Engage, treatment, again, treating these individuals effectively. Transitioning, we've talked about warm handoffs, or you heard about warm handoffs earlier this morning. And then the last dimension is the one I really want to focus on is improving. And it's really about assessing the fidelity to the model. And that's where our data comes in. And through the initiative, we've identified some really great data points. And one of our partners is the Centerstone Research Institute, and they analyze a lot of our data. So whenever I came on board, almost 2 years ago, working with a handful of agencies, we expanded this initiative with more facilities in the state, and to keep track, I developed a lovely color-coded spreadsheet. So this is where a lot of my data comes from. And it basically tracks the progress of every agency and the certain data points that we're looking for, the certain action steps we're asking them to complete within their implementation strategy. So In Tennessee, we saw that Tennessee's suicide rate is higher than the national average. And that's what really kind of prompted us to look at this and say, what can we do in Tennessee to bring down the rates? So we're hoping that after 2 years of implementation with this particular initiative, we'll be able to drop our rates lower than the national average. Some of the great data points that we've been able to use is one of our agencies, data is great, and I will echo what Maria said. Data is great, but it doesn't do anything, right? You have to have someone mining that data. One of our agencies has a data mining person and identified that this was a community mental health center, and they were able to identify that 50% of their suicides were med-only patients, okay? Would have never known that had the data not been mined. Knowing that statistic, they were able to target the providers in that department, the pharmacists, the pharmacy techs, provide training, implement screening, create policies so that individuals were receiving a little bit different care, better care. Since the implementation, since the training, since the screening, no more med patients are dying by suicide. That's incredible. So we're very, very excited about that. We would have never known that without data, right? We've seen independent agencies are tracking their data very differently. In Tennessee, not everyone has electronic medical records. Some agencies resort to tracking deaths by suicide using an Excel sheet, and that's great as long as you have someone there to be able to mine the data throughout the agency. So that being said, there's a couple different tools that we use to collect data with. Within the initiative, the Zero Suicide Initiative, there's a workforce survey. And so the workforce survey assesses the workforce beliefs about suicide, their attitudes about suicide, and also what trainings they've had or would like to have as it relates to suicide. What we learned from this, and I'll preface this with this, in Tennessee, there's no mandate, no licensure requirement for mental health professionals to have any type of suicide prevention or intervention training in order to obtain licensure. So in Tennessee, families are sending loved ones for treatment to professionals that they assume are qualified to provide effective treatment. By the distribution of the workforce survey, professionals were letting us know that we're not qualified, we're not trained, we're not educated in how to treat suicide specifically. Again, one of our partner agencies implementing this initiative identified that 76% of their staff were not willing, ready, or able to work with individuals who had expressed any type of suicide ideation or attempt. They've never been trained on it. Again, without mining the data, we would never know that. We can't improve our mental health system without data, right? So we hope that we provide the workforce survey whenever the agency comes on board. After a year's time, we have the opportunity to embed trainers within the facilities. So for our initiative, we embedded QPR trainers, question, persuade, and refer. We embedded AMSR trainers, assessing and managing suicide risk. We embedded assist trainers, applied suicide intervention skills training. We also embedded, there are 3 Suicide to Hope facilitators in the state of Tennessee now. And so we embedded these trainers in the organizations, and we charged them with the duty of training their workforce. So for example, facilities, the receptionist, those individuals were identified as the most appropriate group to have QPR training, very basic gatekeeper training. Therapists would receive AMSR, assist training. So we can teach them and they can develop their competency and their confidence so that we can, in a year's time, we hope that the data will show, yes, I'm willing, ready, and able. I believe we can change this for the better. So that's my time.
Good afternoon. I'm Marna Miller from the Washington State Institute for Public Policy that we just all call WISIP because it's quicker. And what I'm going to talk about is a little bit different than the sort of metadata that you've heard about this afternoon. The Institute for Public Policy, where I work, is a legislative agency that was created over 30 years ago by Washington's legislature to conduct practical, nonpartisan academic quality research on topics assigned to it by the legislature. And for about the last 20 years, periodically the legislature asks us to identify what works in different policy areas. And our approach is pretty much the same regardless of the policy area. We look for research evaluations of interventions, and we will gather all the research we can on a given topic. We don't cherry pick, we look for everything. We try to do a complete systematic review. Then we apply a statistical approach called meta-analysis that lets us take all the research on a given topic and combine it. So now we have a bigger sample, we have more statistical power, and we can come up with an estimate of the average effect. That is, if we took that intervention and we applied it in Washington State, as it might be on the ground, what would its effect be? And then we do one more thing, which is we take that average effect and we conduct a benefit cost analysis. So we estimate what, given the cost to provide the program, what are the lifetime benefits to the participant, to taxpayers, and to others of the intervention. And finally, we do what's called a Monte Carlo analysis. Everything that goes into a benefit cost analysis, there's some uncertainty about all the inputs. And so the Monte Carlo analysis allows us to draw randomly from within the uncertainty of all the inputs into the model. We run the model 10,000 times. And then we can say on average, or we can say, what's the likelihood that the benefits, the monetary benefits of this intervention will exceed the costs? So we have done that, as I said, in a number of policy areas. In the last several years, the legislature has asked us to go one step further and to create inventories of evidence-based, research-based, and promising practices. So 4 years ago, we got the first inventory assignment. We were to come up with inventories for children's mental health, substance abuse, criminal justice involvement, and child welfare. And that was quite an effort. And then 2 years ago, we got another assignment to do something similar in adult behavioral health. So and it was a pretty massive, intensive year. But we reviewed a number of, I think 50 actually, interventions in adult mental health and substance abuse. And then we put them together. I don't know if some of you have seen this. This is just an example. This is one page from the Adult Behavioral Health Inventory, the adult mental health. And it kind of looks, our previous director was a great fan of Consumer Reports. So we have solid dots indicate evidence-based, circles with a dot in them are research-based, and then we have promising, and we have, I think, on this list, one that we think is not a good idea to do at all. What we found, I think, is that there are a number of interventions that are effective, especially for what are the most common mental illnesses: depression, anxiety, post-traumatic stress disorder. And I should back up and say that we did not, on purpose, go into pharmaceutical interventions, just because we don't have a pharmacist on staff, we don't have physicians on staff. So these are all psychosocial interventions. But what we found is that there are effective interventions for the most common mental illnesses, and that they are cost-effective. In the area of serious mental illness, there are effective interventions, but typically, if we just look at the benefit cost, we would say they don't return on the investment. Not to say that we shouldn't do these things, but sometimes you see things presented in a way that says, well, if we can reduce, this program has reduced psychiatric hospitalization, therefore it pays off. And frequently that's not the case. So it was that was a hard thing, personally for me, to review these studies and find that there were so few instances where, especially in the area of serious mental illness, where psychosocial interventions really paid off.
Well, thank you very much. Let's just give a quick round of applause to all of our presenters before we jump into the question. We are running a little bit late, so we're going to try and move through at least one question to all the panelists, and then we'll open it up for the audience to ask questions and contribute. I just want to quickly acknowledge and thank the presenters for their presentations, and I think that really demonstrate the range of issues that we're dealing with when we think about data to solve mental health, to help solve some of the mental health issues that we're facing. We've heard about the need for evidence-based solutions, and we've heard about a few jurisdictions that are implementing programs with fidelity to these evidence-based frameworks. We have a resource of evidence-based solutions that we've just heard about. We've heard about data sharing and some of the silos and challenges around data sharing and kind of the need for data sharing. We've heard about collection of new information to help us inform our processes and to improve the quality of our programs. We've also heard about some of the needs for technical support and capacity building around how to use these data to make them more effective, to help promote change. And then finally, I think we've heard about the need for leadership to make all of these things happen. So I think it was a very nice discussion of some of the range of issues that we face when we talk about using data. I did want to ask the panelists just a general question. I think everyone has a little bit of a different stage of their project and coming at it from a slightly different angle, but I would love to hear about the challenges or the anticipated challenges if you don't have your program running yet, or you're still kind of in the beginning phases of the program, about what resources that are needed to better collect or leverage data that is available to collect or use data that is available to inform your program and improve your program. And I'll just open it up to whoever, depending on who wants to answer.
I think from what I'm working with the CBOs that we worked with so far in regards to QI and helping them with their quality improvement programs, is just the issue of finding the time to actually digest the data and understanding how to improve once they receive that data. And that's where we're using the QI and learning collaborative methods to help them make this a part of the culture and their capacity to do it, as opposed to just, giving them the information, let them deal with it the best way they know how to deal with it. We want to encourage them and help them build the capacity to use that data. So that's some of the challenges we foresee, and we're trying to deal with that.
The question is, what are some of the challenges?
Around, so for example, for your program, you have a wealth of data, unlike other programs. How do you best kind of use that program to inform the programs that will affect mental health change?
I think that, we're at the point in our evolution where we have so much data, it's now a challenge of how do you get the right data to the right person at the right time to do the right action, and in such a way that is helpful. So that is, it's an iterative process, this whole thing. It's technology a little bit, and then it's data a little bit, then it's practice, and then it's just, you can't just go this way, data, and have everything follow behind it. It's very iterative. And so that's a commitment in and of itself to work with people around data. What does it mean? It means something very different to a primary care. We made a commitment from the very beginning that we wouldn't just look retrospectively and understand populations, that we would get the data to the practitioner in the moment of truth and make a difference. And so that, and we all know how complicated population health is and how you interpret it and stuff. Well, imagine taking this intense, complex data and making it applicable to a primary care physician who has 7 minutes versus an intensive case manager who has, an hour and a half or half a day or, 11 months. So what do you say? What's just chatter? What's actionable? How do you make a fourth language? Because these systems of care have their own language. Medical has their own language, mental health, substance use, social services, they all have their own language. So how do you make a fifth language that they can all understand? And that takes time. So I now have a primary care physician on my team to help take integrated data and have it make sense to a primary care physician, the medical side of the house, and I have a care coordinator who does that for the social side of the house. And now we're going to be moving to shelters. What of that information? And with technology, 2 years ago we couldn't do it because we couldn't do role-based access. And now we're at a point where we can say, you're a shelter case manager, you only need to see this much. You're an intensive case manager, you need to see all of it. And I can now track and make sure that you're seeing only the data that you should be seeing. So it's fairly iterative, and it's a lot of work. And I think it's the commitment to see that through.
First, I want to echo the right data at the right time, because I think at the end of the day, how you use it and where it gets used, and helping folks in the community filter out what they don't need. But for us, I want to go back just to size and the challenges. We have a number of different agencies and departments. We all collect data a little bit differently, so we have data silos. And even when we think we might be collecting the same data, just asking about things in a different way means it's hard to knit them together into a comprehensive picture. So getting the right folks to the table to talk about and bring all these things together and figure out how do these pieces fit together, or do we need to start to change the way in which we collect and look at data so that we can use it together in a better way. And we're doing that right now, just within the children's system of care. We're working with the Department of Health, Public Health, DCFS, and DMH. Every kid that is removed goes through a screening at a medical hub. Every single one of our departments is there. And we thought we would get all our data together and put together this presentation about the different work we're doing. And even though we're seeing the same kids, we found the differences in how we collect data made it really hard to tell one story, and realize that that's where we needed to start. We needed to step back and just look at how we approach each of the things that we do, and how do we pull all these pieces together and make sure that that equals better service for the kids and families that come through these sets. So that would be my challenge.
We had a lot of challenges with this initiative, but we've overcame so many of them that we're truly making a lot of great progress. Tennessee does not have the National Violent Death Reporting System, so we have no real lifetime data that we're able to analyze what we're doing with to see if it's making a difference. So we have to wait typically a year, 2 years to see what the rate is and look at, okay, what were we doing 2 years ago that maybe the rate dropped? And so hopefully, we'll be able to change that. To kind of echo what you were saying a little bit about looking forward and being predictive, one of the other ways we're using the data is predictive in a predictive manner, so that if we're able to look at the data and analyze it and identify patterns and risk factors. If you look at an average older adult white man who's divorced and suffered a job loss, In one of our agency systems, anyone who is an older adult white male with a job loss who's been divorced will automatically be flagged, and therefore the therapist will know that, okay, this kind of needs to be on your radar a little bit. He does have all of these risk factors. He may say that he may screen negative on the Columbia, but you still maybe need to probe a little bit more just to be sure. A lot of our agencies did not have electronic health records at all. So identifying and coming up with creative solutions on how they can track certain information was challenging, but again, we were able to overcome that. And one of the challenges that we're facing right now is if you think about some of the trainings that I mentioned earlier, the train-the-trainer events for these are 1 day or 2 day events, or, training the workforce is a full day. And that affects the bottom line. That affects profit, that affects everything. So that's still a challenge that we're working with. One of the suggestions we've come up with is working with the MCOs, and hopefully they can offer grants to our agencies and say, okay, if you're gonna implement this training, then we'll give you this much money to do that, so.
Well, I think the challenge in our work was it's challenging, it's always challenging to do that kind of work, but I think the next step is actually taking those inventories that we created. And I should have mentioned earlier that the agencies in Washington that provide mental health and substance abuse service have been directed in legislation to increase the use of evidence and research-based practice. Right now, and the children's inventory came before the adult. And so right now the agency is starting to get a handle on what kinds of therapies and interventions they're actually paying for. In other words, what does 1 hour of individual therapy mean? Is it CBT? Is it supportive therapy? So until this legislation came along, they really didn't know. So the challenge is, first of all, if the agencies are under direction to increase the use of evidence-based and research-based practice, first of all, they have to know what's the baseline. An increase above what percentage? So that's the first challenge. And then I think the second challenge is in having a workforce trained and able to provide the evidence-based practice. I don't know I gather it's a universal problem, but certainly in Washington, we're pretty beleaguered in terms of trying to keep psychiatrists on board in the state hospitals, for example. And that doesn't even speak to whether people can, whether therapists are trained to provide cognitive behavioral therapy for depression or not. So I think knowing what the baseline is and then having an adequate workforce are going to be the next big challenges.
Any follow-up? Okay. So before I open this up for questions from the audience, I guess I wanted to ask a question to you related to this issue of challenges around data to inform our mental health programming, and if there are examples from the audiences where you've had a challenge, or even success stories where you've surmounted a challenge, or what the general needs are to demonstrate the impact of programs that are happening around the country. Good, we have somebody.
I'm actually emailing some of you guys while we're sitting here talking, because I want to talk to you after this conference. So my name is Dr. Nicole Adams. I'm the Deputy Commissioner of Health Affairs for the New York City Department of Corrections. So I work on Rikers Island. So this is our challenge. We do not have access to data at all, whatsoever. We have a very interesting system where health and hospitals by New York City charter provides all the medical and mental health services. And as the Commissioner of Health Affairs, I'm responsible for being that liaison, but also making sure that the inmates in our custody and corrections get all the care that they need. So not having access to data is, oh my gosh, it's so challenging. So my question to this panel is, I know that wasn't your issue, Ms. Martinez, but because you had people that gave you permission, but we're in a very great place in New York right now where this conversation is at the highest level, supported by Thrive and our New York City mayor, and they're looking for proof that we need, like what kind of access we need to do the work that we want to do. And I hear you, we need the evidence. So the other challenge that we have is, and I don't know how much this applies to the rest of the people in the room, but if you're not a data person, so the data is only as good as it is accurate, the people putting it into the system. So it's brand new for some of our individuals that are entering this data to kind of get into the mindset of, okay, we have to do data entry because we need this to prove that we need certain pieces. So 2 questions. 1, do you have suggestions about like what are good things to say as far as why we needed to do our work effectively? And 2, how do you support a culture of getting people to be more data-minded so that they're entering and collecting information with fidelity?
So I'm going to jump in because I've been asked to repeat the question. But I think I'm going to do it very concisely, but I really appreciate all of the context that you provided for that because it's a very real struggle. The first question is how can you promote data sharing in the context of government bureaucracies that are more resistant to data sharing, especially when you have a very vulnerable population at risk? Is that okay? Okay. And then the second question is, sorry, I'm blanking, is, how can you promote the value of data, especially with respect to data entry in organizations that are collecting data?
Well, my head's going to blow up, so I'm going to go first.
I just sent you an email.
Data integrity is an issue, and the only thing I have found work is when you shine light on it, when you give feedback quickly on it, it changes. So that is wherever you go, data integrity is. For us, we had 15 databases that we could say if 6 of them said he was African American and 5 of them said he was Native American and 3 said he was white or nothing, we went with the African American. So we reconciled things that way, the highest number. And some data sets can be trusted more than others. In terms of sharing information, I didn't mean to make light of how much work and process there is to convincing agencies that they need to share information. I guess my question for you is, are you looking at this as a perspective of the criminal justice system needs health data, or are they health people inside the criminal justice system?
Sure, so these are detainees that, so for example, because I'm working.
I mean, the people who need the information, are those health professionals, or are they?
The administrators that are supporting the services. So for example, we need data to drive placement, for example. Right?
So if it's health data created by health individuals, then sharing health data with other members of the treatment team, which could be the hospital or the outpatient, is covered by law. Mm-hmm. That is simply a practice issue if there's resistance in data sharing. Or it might be a security issue. They may not be able to yet do it securely. But the privacy rule allows for members of the treatment team to share information, so you're covered that way. So you have to keep going back, and I don't know if New York has special kind of laws, California has some special laws, but I would say as an approach, what we have found to work in San Francisco is when the mayor hires a data sharing officer and has legal counsel with the idea of how do we make this work, as opposed to the city attorneys who say why you shouldn't do it. And you have a city attorney for each agency, and they bicker and they move on and they change, and it's awful. The mayor created with my total thumbs up of a data sharing department that convenes all these people together, and the city attorney's office really had to, if they weren't going to get on it, his legal team was going to get on it. And so that has been really significant, because we can talk about when is an authorization form required, when is it not. Let's have the same authorization form, not different ones. Let's talk about data security and make sure there's a standard that every agency, in the city of New York. So that has been really helpful, because individual agencies, it's a lot of work to do interagency data sharing. And I leave and she comes on and it's not a priority for her, so it dies away. So having a central third party, if you will, that's whole purpose is to make that happen is critical.
Okay, go ahead.
I'd like to add also, I think it's a lot of it also is changing the culture from the bottom to the top. When I interviewed for this position, I won't say who said it, but the person who interviewed me said, you know, the data we have, it sucks, pretty much. I don't know if you heard me, it sucks. And us in the Department of Health and Mental Hygiene, we're asking for data from other agencies, and the wall that we're facing is just unbelievable. So I completely understand where you're coming from. And I think it's not only having people from, and like the people who are doing it in the front line, but people at the top understanding the value of sharing data and us coming together. The agency heads need to come together to just address that issue that we need to share our data so that we could drive improvement. And I think in terms of data integrity and people at the lower level, frontline staff understanding the value of inputting data that has integrity. I think also engaging them and helping them understand the importance of why this data is necessary. And so for example, the community-based organizations that we're working with, we're doing what's called Plan, Do, Study, Act cycles, where they're actually a part of the change. And so they identify an issue within their department, and then they're utilizing data to help drive the implementation of that initiative. So I think it's not only engaging them in just the data entry portion of things, but helping them become part of the solution as well. And I think that change has to occur from the top and the bottom. So.
And then I just want to jump into, for us in Los Angeles County, we have a number of really large departments. We share the same populations. And so HIPAA allows us to, we believe Interpret is allowing us to share data for purposes of care coordination. But just to strengthen that, we have a number of MOUs in place across for each of our departments to kind of outline what that looks like and how we share data and, you know, and outline security as well. And that's been critical for our ability to work together, particularly with Children and Family Services, particularly with jails. You know, I think we really look at shared ways of asking for authorization and making sure that folks we work with understand we work together.
Those are all public documents. You can ask for copies of them.
Yeah, and then when it comes to data integrity, it is always a challenge. And for us, especially when we look at individual-based outcomes for each of our EBPs, and we've got thousands of folks in treatment, the one strategy we try to use is we give a lot of feedback centrally to individual providers and agencies, and that's one of the quickest ways to get people to shore up their data integrity, because you either see things that are slipping or falling, and maybe data just raises the red flag. It doesn't tell the whole story. So either what's going on here, are folks maybe not entering, or is it the case that we need to do some work? Is this not the right practice? So feedback and communication, some sort of feedback loop, to us has made a really big difference.
Okay, let's go with another question or comment from the audience. Yes, in the back.
From a field of work that...
Can you please introduce yourself? Thank you.
Joe Yancey, St. Louis, Missouri, St. Louis Regional Health District. From a field of work for a long time that relied on powerful stories of people getting better, of work that was almost heroic, but again, was more narrative, to where we are now, not just in behavioral health, but in healthcare in general, where it's not about what you do, but it's about what difference did it make. Mm-hmm. That is a challenge to most of us in behavioral healthcare, because our good friends on the community health world were much quicker to this, or better. Actually, they had resources than we did not. But having said all that, the biggest challenge that I think I see is really that cultural change within our organizations and within our systems. And again, I think a lot of that has to do with the fact that this is relatively new for us. And, you know, frankly, even our system as a whole hasn't been around that long, really, when you think about it. What advice do y'all have in terms of those kind of cultural changes? I think, Ms. Martinez, you hit on it briefly, or somebody did, but I think that is our biggest, my sense is, when we do electronic health record, we can really work on data integrity. We can do all of that things, but if we don't have a workforce that says this is important, we get it, we're moving forward with it, then it's just really hard. So any ideas you have?
So I'm going to restate the question. The question is about what ideas do we have about how we can change the culture around mental health and data collection, use of data in mental health programming.
I think for all the behavioral health people, 'cause I come from the multidisciplinary, we have it all, but I think for the behavioral health people in this room would be to understand how powerful your data is and to share it, be willing to share it. The medical side of the world of the safety net is paid to take care of the medical parts of the safety net. And I used to try to talk them into thinking differently about high users, and now I don't know, they wore me down or whatever, but now at least I say to them, fine, you define your high users, high-risk people, whatever way you want to, and believe me, Medicaid does that. Atul Gawande did that. But you need to know everything you can about that high user, high-risk population. So I was sitting in a room and they were talking about high users of durable medical equipment. It's really expensive, off the charts. Talking, coming up with interventions about how to fix that. And I said, if I told you that half the people, those high users of durable medical equipment, had depression, half of them were homeless, would you have a different intervention? Yes, we would. I said, then you need to have that understanding of the population that you define as high risk. And behavioral health, mental health sits on that information, and it's really important that you approach your medical counterparts and say, let's share and understand our high-risk populations together, because they are going in and out of these systems of care without each other coordinating that or understanding it. So the power you have in this room is significant. And if we were in another room and they're all medical people, they would say the behavioral health people will never share their information with us. They say that they can't, and you can.
I would also say that the Zero Suicide Initiative, the 7 dimensions, are organized in a very strategic manner, with leadership being number one for a reason, right? You're from Missouri, is that right? Your rate is a lot higher than the national average for suicide. And I'm not sure if you knew that already. Yeah, okay. So, I mean, even using that kind of data to get leadership buy-in can be very instrumental. A personal touch or learning more about the leaders in the organization. You look like you're ready to say something.
I appreciate all that. I guess maybe I wasn't real clear, but what we're struggling with is our workforce understanding and utilizing data. So it's not about how do we help to improve the health of the people? That's what it really should be about. So we need to be looking at both population health from that perspective, but we also have to be looking at it in terms of, well, is Johnny getting any better? And if he's not getting any better, then let's get into that PDSA and figure out what's going on, or some other quality improvement component. And in that kind of culture where you're constantly working to get better and better and better, and you have your outcomes get better and better and better. That is what's formed to behavior.
So to restate the clarification, we're talking about both population level outcomes and individual level outcomes, and the change in the workforce culture to achieve better both outcomes, both individual and population level outcomes.
For so long, guys, let's face it, it was just about maintaining the people in the community. That's what we did.
Right, it was a Band-Aid.
They're getting better, where they're not going in the hospital.
Right, we tried to put a Band-Aid on it rather than really address the issue. And again, my silo is the Zero Suicide Initiative. It's about creating a competent, caring, and credentialed workforce to better treat the population that we serve. And we're able to identify and look at the data from recidivism, I can never say that word.
Recidivism.
Thank you. Yeah, teamwork, see? We can look at those types of rates, and hopefully after, a year of implementing the initiative, we're seeing those rates go down, right? We have agencies that share data with each other in the medical examiner's office to make sure that we're not losing our patients to suicide. But it does start with the leadership and making sure that the workforce knows it's not a flavor of the month. This is continuous communication about the initiative and what's expected and how leadership not only wraps around patient care, but also staff care, right? So that your staff feel comfortable addressing the issues, so.
I just wanted to add about the use of PDSAs. I think it's easier said than done. I think a lot of organizations that do it well, the leadership help the workforce to set aside time to do it. I think a lot of times these organizations that implement intervention after intervention to try to prove things, a lot of times the frontline workers are just tired of hearing about it. This is the new flavor of the month, and is this going to be the one that changes things? We don't know. But I think instead of it just being top down, I think the leadership set aside, telling the workforce, I'm going to have you set aside time to focus on this, and have them be the ones to drive the solution, have them to be the ones to identify what the problem actually is, and then identify the data that's going to be helpful for them to, to create a new solution, and then to implement that solution and track how it's changing over time. But I think it's, just telling them this is what we're going to be doing, we're going to be utilizing data is probably not enough. Is really emboldening them with that change. I think it's going to be important to make that cultural change, and that's just one step in that process.
I think asking them as well what, I asked one time the homeless outreach team, when you go home at the end of the day and something happened and you went, yes, what was it that happened? And so asking them, to think about those measures differently. And for this person, he said, I went home and I went, yes, because I got someone to do his laundry for the first time in 10 years. And now, so how do you measure those kinds of things? And I think that we have to really challenge ourselves to say there are ways in which we're making a difference that Medicaid doesn't even understand. I mean, there are ways that we are touching people that's more than just making sure they're not dying. And what are those? And it's an art form.
So, okay, one last comment.
I'll be super quick. For us, I just want to say it was a resource. It's definitely a resource investment. So with PCIT, for example, how do we get our folks to utilize and work with the data? We have a team that's really dedicated to working with each of the trainers. They set up learning collaboratives. They're talking with the providers on a regular basis. And it's that feedback loop that I was talking about before, really driving it home for them so they could see the outcomes of their work. But it means investing in the resources and the workforce to be able to do that. And that was key for us.
So this is, we have to end, but this is such a great way to end, because I think what's really hitting home is that we need to be very innovative in the way that we use our data, both in terms of informing our workforce, informing our stakeholders, informing our policymakers, informing our data privacy officers who are maybe not so excited about sharing data. So with that, I just wanted to thank all of the presenters. And I wanted to give you an update about the next step, which is the next panel. At 3:40 will be the third and final panel breakout session of the day. Act Early will be in the Bateman room, which is that way based on what I've seen in the larger room today, the pointing in directions. And then Change Culture will be here in the Constantino room. So thank you, and thank you to all of our presenters.